of infection. So after I have zeroed it, how do I zero it? I open it to the why am I doing it? Atmosphere? Because the effect of atmospheric pressure, considering the atmospheric pressure and any other thing hydrostatic is minus उसको pressure only pressure the tip of the catheter the patient's arterial blood pressure, right? So now after that okay, you can see it here and open it to the atmosphere. IP pressure 0. I see the channel where it is done, and if it was attached to a patient, it would have given the zeroing down. How many times do you zero it? Okay. Now suppose this is open here, this is open to the patient. This is not connected. Now let us say an arterial trace is coming, but suddenly there is a change in arterial pressure, sudden drop. Okay. Or you see the curve which was coming, their morphology has changed. Then what do I do? Yes. Now I have to know whether there is anything wrong with my setup, the arterial catheter and the transducer and my entire setup. So for that, what can I do? First, you ensure that there is free flowing in the arterial line, right? It is coming. Free flow as you can also aspirate amount to see whether there is free flow in the tissue. Then I have to know whether there is something wrong with the system. For that, there is a test of accuracy. I have shown it. What do I do? नहीं, आपका लेवलिंग हो गया, लेवलिंग करके आपने पोजीशन फिक्स कर दिया ट्रांसड्यूसर का, आपका जीरोइंग हो गया, with that now you are monitoring the patient's blood pressure. Leveling done, zeroing done. What do I do next? I showed it. Flush test or square wave test. For that क्या करते हैं? The same way you flush the arterial line with the tap, you give a sharp pull to it, and people try to watch the model. There was a fast rise, then flat on the baseline. So what happened in my case? Quickly it returned to one oscillation, it returned to 0. Or square test, because I have shown you the waveform is square. Okay. So how do I interpret the data? Suppose your arterial, this was the tracing waveform, and now you are getting a waveform like this. This looks like an overdamped graph. That means consider this to be a shock absorber. It's absorbing too much shock. That is, it's absorbing some amount of your pressure also. What are the conditions when it can happen? There are air bubbles in the system. If it is kink, this is loose. Say if there are blood clots, if there is arterial spasm, this can happen. So how do I know other than the shape of the graph that is overdamped? See, after a flush test, what happened in this case is it very quickly, less than 1.5 oscillation, shorts, just comes back to the normal baseline. Whereas in a normal, actually properly damped system, will be at least 1.5 to 2 oscillations. So before it comes to the baseline. In this system, there is a lot of air bubbles I can see. There are a lot of kinks here. So if I do a flush, see, sat, it has come back to the baseline. This is an overdamped system. And This is an under damped tracing. What happens is there will be more than 2 oscillations before it returns to the baseline. When it can happen, if there is this tubing is too stiff, if this tubing and if there is hypothermia or there is tachycardia or dysrhythmia, this can happen. उसमें क्या होगा ना, systolic pressure more, but important thing is the mean arterial pressure will remain unaffected. So we have done a flush test, we have done leveling, zeroing and flush test. After this, how much pressure needs to remain at this? Yes, more than 200, so usually we keep it at 300. What will happen? I mean, 300. Why do you keep pressure in here at all?
Backflow.
Okay, before that, let me ask you, is there any flow from this circuit, this system into the line?
Actually, we are measuring that exertion, means fluid, the pressure from the fluid column. That's why
we are measuring the pressure from the fluid. This ensures, number one, that the system remains patent and there is a flow of around 3 ml per hour into the circuit. Okay, so that it doesn't get clogged. It's a very low flow, it will keep the system clogged. I said that if there is too stiff, right? Perhaps I should discuss that, but what happens in it's too stiff is, you know that every system has its own resonance. If it is a too stiff resonance, sure. Suppose this is my flebostatic axis, is fixed here, okay, or maybe it has slipped down here. Difficult to show, but dhar upore. Is there going to be any change in pressure recorded by the system? My flebostatic axis is here and your transducer is here. What will happen? Lower or higher? Right, lower. And if it is down, under? Reason? Always find the reason, then it will be easier to, there is no guesswork. Because I have zeroed it at this level, right? And it is reading the level of the pressure. Now, if it is lower, it will also record pressure of the hydrostatic pressure, pressure of the fluid column. And if it is above, lower pressure will be recorded. What is seen is for every 2.5 centimeter, every 1 inch or 2.5 centimeter, the heart is offset from the reference value. A 2 millimeter mercury change in pressure is recorded. So, say 10 inch, अगर 10 इंच नीचे रहा तो प्रेशर चेंज कितना होगा 20 millimeter of mercury, 20 millimeter of mercury more, and if it is above 10 inch above 20 millimeter mercury, it will falsely record arterial blood pressure. Achha, any other question? Okay, why did I talk about those not related? Heparin. Is there any problem in keeping heparin in the system? The simple reason why, in our hospital we avoid heparin flushes, especially in this system. HIT. Heparin in the system can cause thrombocytopenia. It is called heparin induced thrombocytopenia. That's why. Now any question from your end? Feel free to ask. इतना टाइम किसी को मिलता नहीं है वार्ड में, हम लोगों को कभी नहीं मिलता है to clear your queries. And remember the steps. Since you have not done it yourself, it is difficult to remember the steps. करना पड़ेगा अपने आप. You have to do it by your own hand. तो उसमें steps आगे पीछे हो सकता है. But the important thing is for you to take home the concepts of flush test, which is to measure the accuracy of the entire pressure transducing system. Number 2 is leveling. Number 3 is zeroing. Leveling here at the in the phlebostatic axis, zeroing every time you change the position of the patient, every time you draw a blood sample or anything. After that, you are to zero the system, so that all other pressure effects are negated and the system only measures patient's blood pressure. Any question? তাহলে ওইটা ক্লিয়ার তো? যদি ট্রান্সডিউসার নিচে থাকে কি হবে? কি হবে? বেশি হবে, falsely elevated. যদি উপরে থাকে falsely low. ওকে, হ্যাঁ। যদি ইয়ে হয়, ওভার ড্যাম্পড হয়, মানে if there is air bubble in the system, if there are kinks in the system, blood clots in the system, then nahi তা না, what change will I record in the blood pressure?
Blood pressure remains the same.
No,
But the graph will be same.
গ্রাফ তো চেঞ্জ হবেই, তার সঙ্গে কি হবে? See, peak is low, it's an overdamped graph, so systolic blood pressure will be low. Diastolic blood pressure may also change, but map will remain same. Conversely, under damped system তাহলে কি হবে? পিক যতটা প্রেসার দিয়ে আমার ওটাকে pressure is more excited, more peak, so systolic pressure will be falsely elevated, right? And but here also the map is usually accurate. हाँ, क्या? Showed you? Okay. Peak systolic pressure is the maximum left ventricular systolic pressure begins with opening of aortic valve. Peak systolic pressure. This is the diacrotic notch, and this is the diastolic pressure. This anacrotic notch is not seen in peripheral pressure monitoring. It's only in the central. And this difference is, what is this? Pulse pressure. And the area under curve, this entire thing is mean arterial pressure. Mean arterial pressure, as we know, we used to think why is 1/3 SBP plus 2/3 DBP? Because in a systole, 1/3 of the systole, 1/3 of the cardiac cycle is systole, and 2/3 is diastole. So 1/3 SBP, 2/3 DBP. That gives you map. So what is happening here is, even if the waveform is changing, but the area under curve, that's why you're getting the same map. But peak is different, so my systolic blood pressure is different. Okay. If you have any question, feel free to please ask away. Flow, okay, which I had discussed earlier. CMRI में भी शायद flow track है. Our hospital also we have a flow track. So this where it attaches to a central venous catheter, and there is option for attaching another wire to an arterial line. What this monitor does is, and this is a flow track transducer. You do, some brothers have anyway. What this does is, it does a waveform analysis, right? The kind of waveform, arterial waveform I showed you, and from that waveform analysis, it finds out all the hemodynamic data here. See? Now, since I have only venous catheter here, it will show cardiac index, SBI, stroke volume index. This is the SCVO, the central venous obstruction situation, and this is SVV, stroke volume variation. I had talked about stroke volume variation a little bit. What is the significance of stroke volume variation? Stroke volume variation is within a single breath cycle the amount of variation in the stroke volume. It signifies preload responsiveness. That is, I am getting a SVV here. If I see that the stroke volume variation is more than 13%, I know this patient will be responsive to IV fluid. If I give an IV fluid challenge, the patient's blood pressure will increase. This does not involve any pulmonary artery catheter or anything. This does pure waveform analysis. You can only attach it to an arterial line. From arterial waveform analysis, it will tell you all the parameters. Or even to a central venous line. কতক্ষণ হয়েছে গো? Any other question that anyone of you may have? Anyone else want to try their hands at setting up this line? Anybody else? Would you try? You have never done before. You want to try? Go ahead. What's to lose? Come fast. No, this one we are not using, we are using this one. There is also a specification of length of this tubing. It should not be more than 1.2 meters. Anyway, क्या कर रहा है यहाँ पर?
Inflate करना है.
Inflate कर रहा है. To 300 millimeter of mercury, right? You already have an arterial line here. मेरा हाथ में एक arterial line है.
इसको inflate करके air free करना होगा.
And making it air free is a religious process, because if it's not air free, I have shown you what happens if it's not air free. आ गया? अब क्या करोगे? ओके, हाँ.
ये पेशेंट एंड में कनेक्ट रहेगा?
नहीं, क्वेश्चन में नहीं
पहले
कनेक्ट रहेगा.
zeroing
हाँ, पहले एयर में कनेक्ट रहेगा, एकदम इट्स फ्री. सो विल पुल द टैब अप, पुल अप दिस टैब. सॉरी, এই জন্য सॉरी. या एयर फ्री हो गया. यू हैव टू फिजिकली इंस्पेक्ट इफ देयर आर एनी बिग एयर बबल्स और एनीथिंग. उसके बाद क्या करेगा?
उसके बाद पेशेंट एंड पे बंद कर देना है.
नहीं नहीं, अभी नहीं. पहले उसको ट्रांसड्यूसर को लगाओ तो मैंने मतलब इसको तो अटैच तो करोगे.
ये तो पेशेंट एंड में
कनेक्ट होगा. फिर
उसको जीरोइंग करना है.
नहीं,
लेवलिंग.
फिर ट्रांसड्यूसर को फिक्स करना है. मुझे ट्रांसड्यूसर को लेवलिंग करना है. एट द राइट लेवल आई हैव टू फिक्स द ट्रांसड्यूसर. इट मे बी ऑफन यू कैन सी इन अ स्टैंड आउटसाइड द बेड एंड देयर transducer is attached, right? They are also at the level of levostatic axis. Thereafter I'll open and zero it, right? And now we are measuring pressure, and this is also definitely attached. और इस बार अगर हम लोगों का कोई आया कि whether if it's okay or not, then we'll do a flash test. Fine. Thank you. I think you will now be going to another table.